Good day, I'm Jay Doucet. I'm an associate professor of surgery at the University of California, San Diego in the Division of Trauma, Burns, and Surgical Critical Care. Today I'm going to talk to you about the clinical management of chemical and biological events. The objectives of this lecture are to learn characteristics of chemical and biological events, learn the most likely biologic agents, and specifically learn nerve agent management and management of other likely chemical agents. Some traditional thinking about chemical, biological, radiological, and nuclear events is that their use by criminals or terrorists will be too difficult because these agents or attacks are too hard to make. Some people believe these things are unlikely because they're not needed when conventional means are still effective, or some people believe they won't be used because they're too taboo for most groups. However, our history shows that this is not true. Chemical, biological, radiologic, and nuclear events since 1975 to 2004 have occurred throughout the world. Many of these events are politically or ideologically motivated, although some were criminally motivated. Most of them, however, occurred on a small scale and did not retrieve permanence in the public memory. Characteristics of groups likely to use weapons of mass destruction include those with paranoia and grandiosity, those whose constituency is not in the target area, those with a charismatic leader, an escalating pattern of violence, innovation in weapons and tactics, and willingness to take risks. An example of a use of a chemical agent in an attack on the public was the sarin gas attack in the Tokyo subway. This was done by a group called Aum Shinriko, which used chemical and biological terrorism over a period of many years in Japan. This group, which was led by a charismatic leader, Shoko Asahara, attained enlightenment in the Himalayas in 1986. He founded this group in 1987 in Japan, and it was widely popular, particularly among educated peoples, politicians, lawyers, and physicians, as well as those in the scientific community. His group has largely been outlawed, however, it still has a remnant operating today. Asahara himself is currently awaiting execution in Japan. This new religion, which was given religious corporate status in Japan in 1989, was an amalgam of Buddhist and Hindu theology, used enlightened and superhuman feats of following their teaching. There was, of course, a pattern of psychological manipulation, brainwashing, and coercion. By 1994, there were 10,000 adherents in Japan, 10 to 40,000 in Russia, and there were branches in 6 countries, including the United States. Heavy recruiting amongst university and wealthy individuals. They attained more than $1 billion in assets, operated legitimate businesses, and successfully infiltrated the Japanese government and industry. They were an apocalyptic group which predicted imminent apocalypse in 1997, 1999, or 2000. And they perpetuated several chemical and biological attacks. These occurred from 1994 through 1995 in various locations throughout Japan. The attack in Japan on the subway system in Tokyo occurred in several different subway cars at the same time. About 5 million commuters used the Tokyo subway system during rush hours, and 5 different devices were deployed and set off at the same time. There were 11 packages delivered to these 5 cars on 3 different subway lines. These are basically plastic bags looking like IV bags, and these were some of them were wrapped in newspaper. These were punctured with an umbrella at the time of their attack by a member of the group, which then left the car. They used about 6 liters of impure sarin. The response initially, the first response occurred within 15 minutes to the police and fire department. They did respond within 6 minutes of time, and the first casualties arrived about 35 minutes after the attack at the closest hospital. The police had their headquarters set up within a very short period of time, and the identification of sarin as the active agent occurred about an hour and 20 minutes after the attack. The decontamination by the Japanese military took about 4.5 hours to get underway. There were 5,510 casualties, 12 dead, 13 critically injured, 37 with severe injury, about 1,000 with moderate injury, and 4,500 or so with mild injury. The initial casualties were the most severe. There were several deaths with those who handled and were near the packages, especially amongst subway personnel who actually picked up the packages and tried to move them. Immediate action by the subway personnel did reduce casualties. However, there were several people also affected because they attempted to help victims who had become incapacitated. There were secondary casualties of 160 police and 135 fire department rescue personnel, so about 2.5% of rescue personnel were actually affected. Factors that complicated the initial response were initial reports that in fact it was a bomb rather than a gas attack, and gave the responders an inappropriate appreciation of the threat. The on-site hazmat analysis was geared towards industrial chemicals, and they picked up such things as acetonitrile, isopropyl alcohol, and diethylaniline, which were solvents or starting materials in the procedure, but did not actually pick up the sarin, as they weren't set up to do this. It was actually the military that picked up the fact that it was sarin. Poor respiratory protection and contamination control was carried out, and as a result, persons who went in actually to identify the chemical themselves became affected by the agent. The general symptoms of nerve gas in these presenting patients included in the eye miosis, ophthalmoplegia, cloudy vision or dark vision, and conjunctivitis. In the nose, congestion and rhinorrhea. In respiratory organs, dyspnea, cough, and chest pressure. Digestive organs are affected by nausea, congestion, and diarrhea. Muscles are affected by numbness and muscular contraction. Mentally by anxiety and headache. In serious cases developed respiratory arrest, fasciculation, convulsion, and clouding consciousness. Amongst the patients who presented at St. Luke's Hospital with the most severe, those patients who presented with cardiac and respiratory arrest were those most seriously affected. Those who died all presented with cardiac arrest. However, there were some of those patients with cardiac and respiratory arrest who did survive. At the Japanese Self-Defense Force Hospital, those who had nicotinic symptoms, that is, those restricted to muscle weakness, were treated with observation and support. By those who had the muscarinic symptoms, affecting the glands and GI tract, they were treated with atropine and PAM, or 2-pralidoxime. They were also given diazepam for convulsions, and cardiac and respiratory complications are treated by ACLS protocol. The impact on St. Luke's Hospital, the closest hospital, 640 patients were triaged in 2 hours. 90 to 95% of those were ambulatory. 110 patients were admitted. They saw a total of 1,410 patients within 24 hours. And the 5 major hospitals closest to the event were the ones that handled the bulk of the day's casualties. The Japanese Self-Defense Force, chemical and biological response and countermeasures, they used a type of paper which is issued to soldiers to detect nerve agent, and they did their decontamination primarily with sodium hypochlorite, which is bleach solution in dilute solution, and also some dilute sodium hydroxide, which is lye solution. Generally speaking, those patients who arrived alive survived. The treatment protocol was based on a clinical assessment of the patient. They noticed rapid patient recovery in most cases. There were minimal residual effects. There was a problem, however, of secondary contamination of those people who tried to look after patients at the scene. And the patients have been followed up long-term. There have been some patients complaining of long-term effects from the attack. There were some problems with their emergency response. First was the inability to detect the agent rapidly, and there was also insufficient respiratory protection for first responders. Contamination control was an issue because some responders and investigators were affected by the agent, and the on-site emergency medical treatment was inadequate, largely because they weren't able to deal with a large number of respiratory casualties and also did not have sufficient antidote. Tokyo did have some advantages. They had the advantages of earthquake preparedness and dealing with a large number of casualties. And since that time, they've had, because of the attacks using sarin at Tokyo and Matsumoto, they've had increased awareness of this. They now have larger stocks of atropine and 2-PL available. And luckily, sarin is one of the easier nerve gases to treat and is tolerant of some delay in patients who are mildly affected. A perspective is many facilities and jurisdictions are not able to do not do large casualty emergency response training. There's also the issue of having too few hospital beds available for a large number of casualties, as many as 100 at one hospital, with a chemical agent. And there has been an issue in the past of insufficient quantities of chemical warfare therapeutic drugs such as atropine and 2-PAM available. In conclusion, the severity, consequences, and impact of such a terrorist attack is entirely dependent on the training capability and resources of the local emergency response system. The Tokyo Emergency and Hospital Response System was massive, they were effective, and well organized. Let's talk about some specific agents, the biologic agents. I spent 22 years in the Canadian Forces, and during that time had to be trained in response to chemical and biological attacks, both for my personal protection and also for the management of casualties. Military organizations generally are well equipped to deal with chemical warfare, and in fact would deal with the chemical warfare while deployed in the field as essentially a type of harassment attack rather than something that could actually cause significant force reduction. My first exposure to chemical agents was during the Iraq War, where treating Iraqi POWs in the desert. The Canadian Field Hospital deployed there was continually aware of the threat of a chemical or biologic attack. And certainly events since that time lead us to believe that the threat of a terrorist attack using these agents is still present. Although our lifestyle has certainly changed since that time, it is still possible to organize and prepare a response to reduce the effect of such an attack. The use of biological weapons is not new. In fact, going back through ancient history, in all the recorded history of warfare, biologic agents of various types have been used. This is a catapult or trebuchet which was used throughout medieval warfare, and it was used to throw various objects including large stones, wagon loads of manure, Greek fire, which was a type of medieval napalm, spurned ambassadors, and in 1346, in an attack on a Genoese trading fort by the Mongols, corpses with plague were thrown over the walls. The Genoese merchants subsequently decided they didn't want to keep that fort in the Crimean, and therefore they returned to Sicily. However, they brought the plague with them. When they arrived in Sicily, because of the sick people aboard the ship, they weren't allowed to disembark. However, the rats did, and very quickly a massive outbreak in plague in 1347 through 1350 went throughout Europe. This plague attack was actually a very significant event in the history of Europe. It actually decreased the population almost a third, and the population of Europe did not actually recover to this level for over 200 years. The fact of plague being endemic, in fact, has throughout our history of previous centuries is present, and this report of casualties in London from the 1600s indicate that in one day, correction, 1 week, 7,000 persons died of plague. So going back as far as the 6th century BC, there is histories of poisoned wells. In the siege of Kaffa on the Genoese trading fort, use of plague. Pisano used smallpox blankets in his conquest of Central America. The French did the same thing in the French and Indian Wars, as well as the British. There was also use of infected fleas to spread plague during World War II by a Japanese biologic weapons unit. And since that time, there have been incidents involving the use of chemical and biologic weapons. How to respond to bioterrorism? First, we have to be aware of the symptoms of bioterrorism, have the appropriate tests available, and know some of the differential diagnosis. We also have to be able to report an attack to the appropriate public agencies, and how to refer these patients to the appropriate treatment, and also to how to refer the media to those who know the most about the subject. Some good sources of information are the San Diego County Medical Society website, and also the Centers for Disease Control website, www.bt.cdc.gov, which contains a considerable amount of information on biological and other types of terrorism. Some overview of bioterrorism and antibiotics. You should not prescribe antibiotics or vaccines to prevent biologic or potential biologic attacks until there's actual clear evidence of an attack or there's been instructions to do so. There are too many different agents involved and too many choices of drugs. And of course there's a risk of resistance, adverse reactions, and a question of what duration it would have to be given. Also, these may expend local supplies, And in fact, there is a stockpile of such agents available, and these can be made rapidly available. The strategic stockpile was available in New York City in 9/11 within 7 hours of the attack, and it can be rapidly transported to the scene of attack by the CDC and DoD. During an attack, individual physicians, their responsibilities should be to try to keep their offices open, take the appropriate bioagent infection control measures for the appropriate agent. If they have internet connectivity, they can log on to www.emansandiego.org, which is the Emergency Medical Alert Network for San Diego, and the county disaster plans are on this website. And a television can be useful to obtain public health alerts and news information. Hospitals must be prepared to isolate infected individuals as appropriate and to use targeted chemoprophylaxis and vaccination, which will be the best response to these attacks. The county public health unit has its own actions to carry out. They will initiate the investigation of the original case. They'll contact, ID, interview, investigate individuals, conduct specimen collection, collaborate with state and federal officials, conduct heightened surveillance, determine need for treatment of contacts and health professionals, assess need for public notification and the level of notification, mobilize additional resources, and maintain constant contact with the reporting doctor and facility. The most likely agents, as determined by a select panel at Johns Hopkins in the 1990s, was our anthrax, plague, tularemia, smallpox, botulism, and possibly the viral hemorrhagic fevers. The most common symptoms at presentation would be acute respiratory distress with fever, an influenza-type illness, gastrointestinal illnesses, skin lesions, or the acute onset of neuromuscular symptoms and signs. Those are pretty nonspecific syndromes, so other clues to unnatural occurrence of an infection would be an unusual number of patients presenting at the same time with a similar syndrome, a large number of fatal cases, clusters of an illness that are not normally seen, infection that's non-endemic to San Diego, common infections occurring during unusual seasons, an increase in sick and dead animals, or by intelligent information that such an attack may be occurring. Differentiating against bioagents in the flu, the annual influenza season in San Diego runs from December through March. There are rapid diagnostic tests which are commercially available and can be performed on sputum samples to confirm the diagnosis of influenza. There's also viral isolation tests that are available. A negative rapid test does not exclude influenza, but a positive test will reassure the patient and physician. And it's important to remember to give flu vaccines when indicated by CDC guidelines. Infection control measures are important in the defense against biological agents. Anthrax is treated by standard precautions. The patients who have pulmonary infections are not contagious. The cutaneous infections can be transmitted by drainage, but these can be dealt with by simply using standard precautions in which we are normally wearing gloves when handling wounds anyway. Smallpox is dealt with airborne precautions such as TB. Plague by droplet precautions using standard masks for 72 hours after treatment. Botulism, standard precautions, and tularemia, standard precautions. This, of course, assumes that the patient has been adequately decontaminated, which in most cases means removing the patient's clothing and any possible dusts or powders or liquids that are on the patient. Hemorrhagic fevers, these require standard precautions, airborne precautions, droplet precautions, and contact precautions to avoid exposures to blood and blood products, particularly from hemoptysis or hematemesis. Any blood-stained material may be infectious. So these are the standard precautions, and they are the same standard precautions we use in the hospital on a daily basis. With these likely bioterrorism agents, we'll discuss which each of these are. Anthrax is a small gram-positive rod that will form spores under a certain condition. It can be cultured from sputum and from blood, and is an unusual organism in daily practice. It is sometimes forms short chains of rods. Its attack basically can be either by skin, intestinal, or pulmonary. It's thought that a terrorist attack would be using spores, which would be ingested by the pulmonary route. The symptoms, however, of each type of attack are somewhat different depending on the route. However, all of these attacks eventually cause the bacteria to propagate within the macrophages, which leads to a release of toxins. And this toxin creates a regional hemorrhagic lymphadenitis, which leads then to septicemia and toxemia, a shock syndrome, possible meningitis, pulmonary edema, and death. The incubation period for inhalation anthrax is 1 to 6 days. The prodrome is from 1 to 2 days of fever, malaise, and dry cough. The patient will eventually develop severe respiratory distress and septic shock, and they develop a hemorrhagic mediastinitis, which leads to a typically widened chest X-ray mediastinum. Traditionally, the mortality was very high, 97% in 24 to 36 hours after presentation of symptoms without treatment. However, treatment during the most recent anthrax attack actually was very effective, and death did not occur in patients who received antibiotics early enough in the onset of symptoms. Day of onset of inhalation anthrax can be very much spread out depending on how spores are distributed throughout the environment. During the inadvertent anthrax release in Russia, the anthrax actually caused symptoms and presentation of anthrax symptoms anywhere from 2 to 44 days after the incident. One of the characteristics of a biologic attack is that often the symptoms and presentations are spread out over many days, and therefore it does not often occur as an acute event, but actually as an event with an apparent slow or unnoticed onset. A chest X-ray in a patient with anthrax shows the typical mediastinal widening. This is usually present on the second day of the illness. It can also cause cutaneous lesions. This is more commonly associated with anthrax gotten from environmental sources. However, can occur when somebody does have a large number of spores on their skin. It can cause this typical blackened eschar appearance eventually. Black eschar is one of the hallmarks of anthrax in the skin location. It can also have an appearance that looks somewhat like a spider bite, and in fact one of the anthrax victims in the 2001 attacks was a baby who was initially diagnosed as having a spider bite on the arm. Diagnosis of anthrax is confirmed by culture of the blood or sputum. It's a gram-positive spore-forming rod, which is unusual in normal practice. The gram stain of the blood is rarely positive. There is an ELISA test available to detect antigen in the blood. Isolation precautions are standard after decontamination of the victim. Anthrax treatment generally is more effective if given before symptoms are effective, and typical treatments could include ciprofloxacin or other quinolones, doxycycline, penicillin, or streptomycin. There is a vaccine available which can be given after exposure. It's given at the time of presentation at 2 and 4 weeks in a combination with cipro or doxycycline. Antibiotics alone can be used, and post-exposure they're recommended for up to 60 days. Plague is a small gram-negative coccobacillus and can be seen on a blood smear in patients who have septicemic plague. Patients with naturally occurring plague can develop buboes, or a swelling over lymph nodes, which is therefore gives the name bubonic plague. Can also have ecchymotic bleeding into the skin, and patients recovering from septicemic plague can develop acral gangrene in the digits. Bubonic plague is vector-borne and causes adenopathy. It's most likely to be associated with exposure to rodents and fleas carrying the plague. Pneumonic plague, however, is the form that may be most likely during an attack, as plague bacteria would be spread by an aerosol. The incubation would be 2 to 3 days, would cause fulminant pneumonia, bloody sputum, and septic shock, could lead to ecchymosis and DIC. The mortality would be high, perhaps 1/3 or more. However, it would respond to early treatment. The diagnosis would be made by a gram stain of the blood, sputum, or by a lymph node. Small gram-negative bipolar staining coccobacillus is typically what's seen. A DFA or Wason stain is the typical stain used, and there is an ELISA test available for serology. In the pulmonary form, plague is highly contagious. Patients with plague would have to be in strict isolation until they were treated for at least 3 days. The treatment options would include streptomycin, doxycycline, or chloramphenicol. Prophylaxis would include doxycycline or cipro. Cipro may also be effective for treatment. Tularemia is a small fastidious gram-negative bacillus. It's named after Tulare County in California. Human infections occur by aerosols. contaminated food or water, arthropod bites, or by skin exposure. In parts of California where this is sometimes seen naturally, it's often labeled lawnmower disease as it occurs amongst those working outdoors. It is endemic amongst the small animals in many counties of California, and can have different clinical pictures with different routes of infection. However, the terrorists would most likely use it as an aerosol, and therefore pneumonia would be the most likely use. Inhalation pneumonia with hilar adenopathy and pleural effusions would occur in about a third of cases. They'd have a high fever, chills, rigors, sore throat, myalgias, an elevated CPK, and non-productive cough. There may also be a so-called pulse to temperature dissociation. Untreated mortality could reach 50%, and those are with the pneumonia. And ingestion of the bacteria rather than inhalation is more likely to cause exudative tonsillitis and suppurative cervical adenitis in swollen nodes in the neck. Here's a patient with ingestion of tularemia, and you can see that similar to plague, they have enlarged lymph nodes. This particular diagnosis is difficult to confirm. There are no rapid diagnostic tests. It can be hard to culture. The blood and pleural fetal cultures may or may not be positive. Aspirates of enlarged lymph nodes will sometimes yield a pathogen. The serology can be used for retrospective diagnosis. A fourfold increase in titers above 160 is diagnostic, but this is usually too late as it takes 10 to 14 days to develop. Patient with pulmonary tularemia shows some infiltrates in the lower lungs, some tenting of the diaphragm, possibly by pleural effusion. However, this chest X-ray is very nonspecific. Treatment is with gentamicin, doxycycline, a chloramphenicol, or erythromycin. Ciprofloxacin may also be effective. The prophylaxis for those possibly exposed would be doxycycline or ciprofloxacin. There's currently no vaccine. Some of the viral agents of bioterrorism include smallpox and hemorrhagic fevers. These often present with nonspecific flu-like symptoms. Vaccination is the most effective prophylaxis, but there are generally either few vaccines available for these agents, or the vaccine programs have been unpopular and patients have not been willing to be vaccinated. There are a few antiviral agents of proven efficacy which are available. Smallpox, or variola, is a disease that has an incubation taking about 12 days. The early symptoms are nonspecific. Patients present with fever, malaise, and aches 2 to 4 days. A rash then occurs, and this has a centrifugal pattern. There is maculopapules which develop the vesicles, which then develop the pustules in a period over 1 to 2 weeks. This is somewhat slower than the process that's seen in chickenpox. Patients are highly infectious during the initial respiratory phase and remain so until the eschar on their pox have fallen off. Mortality was about 30% in the unvaccinated population. Comparing smallpox to chickenpox, chickenpox tends to be mostly on the trunk of the body, where smallpox tends to occur a little more on the extremities. Chickenpox has new crops of pustules appearing over a few days, whereas smallpox, the pox all appear to be about the same stage. Chickenpox has a rapid evolution, as anyone who's had a child with chickenpox can attest, whereas smallpox is fairly slow in its evolution. Chickenpox lesions are superficial, oval, and irregular, and produce only mild scarring, where smallpox produces very circular, regular-looking pox with severe scarring. This is a picture from the 1960s showing typical progression of smallpox infection in a child, and you can see that the pox develops slowly over a period of 7 days. They all have about the same age, and they are predominantly a little more on the head and extremities. Smallpox, if noted, would be an immediate reason to contact public health. Smallpox has been eradicated from the population of the world after initiatives throughout the past century, and reemergence of smallpox would probably only occur as a result of a deliberate attack. To rule out chickenpox, it is possible to do a PCR test to test for chickenpox. Isolation would be strict contact and respiratory precautions. There is a viral antiretroviral treatment such as Cytovir, which could be effective. However, of course, none have been tested, and the isolation is airborne, as the smallpox bacteria are present in aerosols from coughing. Vaccination within 3 days of exposure will prevent disease, and within 5 days can still be life-saving. The CDC had at one time 12 to 14 million doses of vaccine. However, they currently now have enough vaccine to deal with any attack on the U.S. population. An oral vaccine is also in development. Patients who were previously immunized for vaccine, had a vaccination against smallpox during the 60s or 70s, do not have lifelong immunity, and many of those people are now thought to be susceptible to a new attack. The vaccination itself does have some complications. Rarely it causes generalized vaccinia or encephalitis. More likely it's to cause secondary locations of a vaccination lesion, particularly around the face and eyes. The other virals of attack are the viral hemorrhagic fevers, and these are caused by various RNA viruses, usually with an animal reservoir. All these are infectious by aerosol and have high morbidity and mortality, and thus would be attractive to a terrorist. There are many of these, and they have particular distributions throughout the world, typically in tropical and subtropical areas. They do occur throughout the world on a regular basis. In some parts of Africa and Asia, they are endemic, and we do have variants such as hantavirus, which occur in North America. All of these cause a capillary leak syndrome. They have an incubation period of typically 5 to 10 days, and this is followed by malaise, fever, myalgias, prostration, and then appearance of hemorrhagic symptoms such as conjunctival infection, petechiae, ecchymosis, shock, diffuse hemorrhage, neurologic dysfunction, and pulmonary collapse. The patients may also develop evidence of increased liver functions and as a result of hepatitis and renal dysfunction, and these are poor prognostic signs. The diagnosis is based on clinical and epidemiologic parameters. There are definitive diagnoses available for some of the infections by serology, PCR, or viral isolation. The treatment is largely supportive and particularly involves avoiding aspirin or antiplatelet drugs. Ribavirin is effective for some of the viruses. A vaccine is available for other viruses. The isolation is airborne. There are some toxins of bioterrorism which can be used, which don't actually involve live bacteria, but instead they're purified toxins. These include botulinum, staphylotoxin, ricin, and trichlorothecane. The gram-positive anaerobic bacterium Clostridium botulinum is a bacterium which can be used as an agent of biological terrorism. Botulinum toxin, otherwise known as Botox to the public, has actually several different types. It's one of the most poisonous substances known, and it prevents release of acetylcholine at the presynaptic nerve terminal. It can be acquired by aerosol or foodborne routes and typically presents 12 to 72 hours after exposure. Symptoms include the 4 Ds of diplopia, dysarthria, dysphonia, and dysphagia. Patients may have what are called bulbar symptoms, which include ptosis, mydriasis, generalized weakness, dizziness, dry mouth and throat, blurred vision, and respiratory failure. Naturally occurring foodborne botulism is more prone to presentation symptoms of abdominal cramps, nausea, vomiting, and diarrhea secondary to other bacterial metabolites in food, although this is not always the case. Here's a patient with mild foodborne botulism, and it is obvious that when the patient does his best to give a full smile, that he does have some facial weakness. There's also some dysconjugate gaze apparent with the pupils not quite lining up. Symptoms: the clinical diagnosis, the patient will have a symmetrical descending flaccid paralysis with the prominent bulbar palsies. The patient will be afebrile and have a clear sensorium. The differential diagnosis includes Guillain-Barré, myasthenia gravis, tic paralysis, and conversion reactions. This is the presentation of 59 cases after eating food contaminated with botulism at a restaurant, and their time between eating there and onset of neurologic symptoms, and this can vary from 24 to 120 hours. Action: call the public health department, draw at least 30 cc's of blood for a red top, sample the feces, gastric secretions, and vomitus, refrigerate samples and submit any suspect food, and submit a list of patients' medications with samples. There are various tests available to confirm the diagnosis. Patients who have borderline respiratory failure may present in large numbers, and because of the strain on the use of intubation and ventilation in the ICU, some of the patients with milder symptoms may be temporized from having to be intubated and ventilated by a proper positioning. Placing the patient's head up in a 30-degree position may actually prevent the need for intubation in some patients. Decontamination, if it was suspected to be released by aerosol, the patients will require decontamination. The intact skin is relatively impermeable to the toxin, but the skin can be washed off with water, soap and water, or a very dilute bleach or Dakin solution. Persistence of the toxin is dependent on atmospheric condition. Usually by 2 days, any aerosolized botulinum toxin will be inactivated by sun and desiccation. The food is easily treated by inactivation by heat. There is an antitoxin for botulinum which can be used to minimize severity of attack, but it has to be given at the first sign of symptoms, and it will not reverse the paralysis that already has occurred. Paralysis can be long-term. It can occur for weeks to months, and the patient may require long-term respiratory support, nutritional fluid management, and treatment of complication. There is a toxoid vaccine which is still investigational, which is being investigated in patients at high risk and is not effective for patients after exposure. 10 critical steps for handling possible bioterrorism events. Maintain an index of suspicion. In the anthrax attacks of 2001, it was the suspicion of physicians at one hospital which actually allowed the attack to be recognized, and then was more widely recognized once the diagnosis was jogged in people's memories. Protect yourself and your patients. Understand that patients will require decontamination, and know the prophylaxis required for healthcare workers. Adequately assess the patient. Decontaminate as appropriate, establish a diagnosis, render prompt treatment, provide good infection control measures to stop further spread of the agents, alert the proper authorities, assist in the epidemiologic investigations, and know and spread the information. Let's talk about chemical weapons and the medical response to them. Chemical weapons also have a long history in use, and we'll talk about some of those. We'll talk about some of the common agents and their effects. Protection of facilities, particularly hospitals, and the methods of decontamination. Once again, the military is usually quite adept at dealing with the detection of these agents, and they'll, during a conflict, will deploy various kinds of sampling devices to sample the air and identify anything that may actually be deployed. However, even though these systems are deployed, you'll notice from the lower photograph, which shows a canary in a bird cage outside a field hospital in Saudi Arabia in February 1991 during the first Gulf War, as a backup system because of the worry of the possibility of attack and the possibility that automated systems or intelligence may fail. The military, of course, will carry and deploy various kinds of detection systems. However, most of these are not familiar or not available to civilian workers in the hospital environment. Certainly in our recent history, there have been use of chemical weapons. These have been used in Iraq previous by Saddam Hussein, and involve nerve agents, use of blood agents, blister agents, and mustard agents. And these have been used against Iranian soldiers during the Iran-Iraq War, against his own civilians, and particularly the Iraqi Kurdish population. The use of nerve gas, particularly sarin, was started, and later during the conflict against Iran, Iraq used mustard agent. We've already talked about Shoko Asahara and his use of anthrax and sarin. There have also been discovery of other types of devices which, had they been deployed, would have caused significant civilian casualties. Let's talk about the chemical agents. There are four major groups to consider. The nerve agents, which are all anticholinesterases. These include such agents as tabin, sarin, soman, and VX. The initials you see after them are the military initials, and sometimes in some literature, particularly from the military, you'll notice that these are referred to by these letters, such as sarin being GB. VX, which is an agent developed by the British and US militaries, is referred to only by its letter name, VX. Blister agents are another group. These are vesicants, and basically are alkylating agents. These include mustard and lewisite, as well as agents such as phosgene. blood agents or cyanogens, which include cyanide and cyanogen chloride, and lung-damaging agents or choking agents, which include chlorine, phosgene, and certain smokes and vesicants. In comparative toxicity, if you look at the different agents, the amount causing a significant toxic effect for chlorine is almost 6,000 times greater than the amount required for a nerve agent such as VX. The phosgene, cyanide, and mustard have intermediate toxicities. However, chlorine is a much easier agent to deploy for the terrorists than an agent such as sarin or VX, which requires some sophistication to produce. Let's talk about the nerve agents. These are essentially mostly organophosphates which bind and activate acetylcholinesterase. Generally, they are colorless, nearly odorless liquids or vapors, and not really a gas. These include sarin, tabin, soman, and VX. Sarin, again, shows the organic phosphorus compound using these known as essential phosphorus component. This can cause death within 1 to 10 minutes via an acute cholinergic crisis. The nerve agents themselves differ in their toxicity. Sarin it has a toxicity of about 100 milligrams per minute per meter squared, which is about a tenth of that of VX, which is the most toxic known of the nerve agents. How do these agents work? Acetylcholine is a neurotransmitter which is found in the proximal part of the synapse, and with the transmission of a nerve impulse, the acetylcholine is released into the synapse to be taken up by the receptors on the distal neuron, which then allows propagation of the nerve transmission. There are different types of acetylcholine receptors. These include the muscarinic receptors, which are responsible for innervating smooth muscles, exocrine glands, and cranial nerves, particularly the vagus nerve, and also nicotinic. These are found in the skeletal muscles and in preganglionic nerves. Both types of receptors are found within the central nervous system. The effects of acetylcholine depend on which receptor we're talking about. At the muscarinic receptor, smooth muscles are affected, and in the airways, this causes them to constrict. The GI tract, this causes constriction and peristalsis, and in the pupils, it causes constriction, which causes small pupils. At glands, such as salivary or lacrimal glands, these cause actions such as tearing, increased secretions, increased sputum, increased sweating, and increased GI secretions, including diarrhea. In the heart, the effect may be predominantly bradycardia by innervation of the vagus nerve. The nicotinic receptors are those found at the skeletal muscles, and these cause fasciculation, twitching, fatigue, and a flaccid paralysis when there is too much acetylcholinesterase. In the preganglionic receptors, these can cause tachycardia and hypertension, and therefore patients with nerve agent exposure can have either tachycardia or bradycardia. Here's the effect of a patient exposed to nerve agent vapor, and you'll see that the patient's pupils take a very long time to return to normal dilated effect in a dark room, up to 62 days. Acetylcholine at receptors, again, we'll talk about the effect, but there are basically two different types we've talked about, nicotinic and muscarinic. It's important to know this difference because the agents we use for reversing nerve agent act at these two different sites. Acetylcholinesterase is important for impulse termination. To stop transmission of the nerve impulse, acetylcholinesterase, an enzyme that exists in the synapse, has to attack and destroy the acetylcholine that is excess in that area, therefore terminating the nerve impulse until a new bolus of acetylcholine is produced by the proximal nerve. The enzyme of the nerve agent essentially permanently deactivates the nerve enzyme. It does not destroy acetylcholinesterase or acetylcholine, but simply binds the enzyme. That does not allow the acetylcholine that's released to be used up, and therefore the excess acetylcholine persists in the synapse and causes continued nerve stimulation. This causes overstimulation of the end organ. So when the nerve agent, represented by the triangles the diamonds there, attacks, it causes acetylcholinesterase blocking, and there's excess acetylcholine and excess nerve transmission. The symptoms can be found throughout the body. Respiratory, you can have irritation of mucous membranes, cough, airway constriction, and increased secretions. Neuromuscular symptoms such as twitch, weakness, paralysis, and respiratory failure. Autonomic symptoms such as blurred vision, pinpoint pupils, drooling, sweating, tearing, nausea, vomiting, abdominal pain, and diarrhea. And the central nervous system, there can be slurred speech, confusion, headache, convulsions, respiratory arrest, cardiovascular, tachycardia or bradycardia, arrhythmia, or heart block. The management, most importantly, because the toxicity of these agents, it's important to protect yourself. First responders need protective gear, and the casualty has to be decontaminated if there is a possibility of nerve agent being on their clothing or on their skin. It's also important to protect the medical facility, so once it's recognized you're dealing with such an attack, these patients should be decontaminated, ideally outside the facility, to prevent contamination of the facility itself. Early contamination is best, usually within 1 to 2 minutes. There's little benefit after 30 minutes as the agent will be probably absorbed or removed naturally. Physical removal is best, forceful flushing with water. However, such things as sticks, dirt, cloth, M291 resin, which is a military issue item, or Fuller's Earth, which is also sometimes used by the military, can absorb these agents. Solutions such as dilute bleach solution will detoxify, but they are somewhat slow. The main antidote is atropine. Atropine is an anticholinergic blocking agent. It blocks excess acetylcholine by blocking the receptors, but its clinical effect is at the muscarinic sites only. Therefore, it will help dry secretions and help to reduce smooth muscle constriction, particularly in the airways, but will not have any effect on muscle paralysis. So atropine basically comes along and helps block those receptors and decreases the effect of the excess acetylcholine. Atropine, if you have no exposure but are given atropine, of course, there will be side effects. The starting dose in nerve agent poisoning is 2 to 6 milligrams, which is larger than that normally used for initial doses in ACLS protocols. 2 milligrams increments are given every 5 or 10 minutes until there is evidence that the secretions are drying and that ventilation is improving. A usual dose in a severe casualty can be as high as 15 to 20 milligrams, and there have been recorded cases in those exposed to organophosphorus insecticides requiring as much as a total milligram a total gram, or 1,000 milligrams over a course of treatment. The other antidote group are the oximes. The oximes act only at the nicotinic strength, the nicotinocytes, and they're important in increasing skeletal muscle strength. It has no effect at the muscarinic sites. Basically, 2-PAM actually goes to the acetylcholinesterase and actually basically removes the nerve agent. This removes the agent from the enzyme unless a process called aging occurs. Some of the nerve agents, after a period of time, will have made a permanent binding to the acetylcholinesterase, and therefore oximes will have no effect. The aging time depends on the agent. For SOMAD, which is also called GD, that occurs within 2 minutes. Therefore, oximes will have little effect on these patients. Sarin, however, it takes 3 to 4 hours before this effect has occurred. Therefore, oximes can be used in sarin gas. The aging, once occurs, makes 2-PAM ineffective. The oximes, the typical one that's available is pyridoxine chloride, which is also called 2-PAM chloride. 1 gram IV is given over 20 to 30 minutes and can be repeated in an hour. Doses are adjusted for children and elderly patients as shown. If 2-PAM is given in excess, it can cause hypertension, and that is treated with ventolamine. The Mark I autoinjector is the most common type of autoinjector used by the U.S. military and may be seen by civilian practitioners if distributed during evidence of a nerve agent attack. There are 2 syringes. The small green syringe contains 2 milligrams of atropine, and the second larger syringe contains 600 milligrams of 2-PAM chloride. It's important to know that an individual patient may need several doses of these agents, and a soldier deployed to an area of nerve agent intelligence of concern will carry 3 or more of these. Seizures are possible. And generally, they are not prolonged and do not occur for a long period of times unless someone's been taking pyridostigmine as a nerve agent pre-treatment to reduce the effect of nerve agent. Pyridostigmine is typically given to soldiers when there's a large risk of nerve agent attack, and these patients can have prolonged seizures with possible brain damage, and therefore will carry diazepam or Valium. Diazepam or another benzodiazepine can be used in any severe casualty with convulsions. Blister agents or vesicants have been caused most of the casualties in chemical warfare in World War I and are still used due to their wounding effect and tear effect. The general lethality is low, under 5% for an attack. However, their injuries that they produce are quite disabling with long, labor-intensive convalescence. The causes, these basically cause cell damage, tissue necrosis, toxic byproducts, metabolic acidosis, and these are done by essentially alkylating DNA and therefore causing problems with cell growth and division. The classic agent is mustard. This has a latent period of several hours before symptoms do occur. It does appear with erythema and blisters on skin, skin irritation, conjunctivitis, mild upper respiratory symptoms. These can progress to marked airways damage and significant skin lesions. There can also be GI effects, including nausea, vomiting, bone marrow suppression, diarrhea. These can be decontaminated with water or dilute bleach solution, and they're treated with topical antibiotics, pulmonary support, and analgesics. Another agent is Doucet, which differs from mustard in that it does cause immediate pain and does also cause immediate skin and mucous membrane irritation, which then does go on to the erythema, blisters, and skin and eyeway injury. It also is treated with water or hypochlorite, and does have an antidote which is called British anti-Doucet, which is 10% solution in oil. This is a patient being treated for a mustard agent burns in a Swedish hospital about 6 weeks after injury. Shows an extensive injury several weeks old, which is only beginning to heal. And unlike a thermal burn, these mustard burns can be very slow to heal because of the effect on DNA. This is a more acute lesion seen in a fisherman who accidentally drug up a mustard shell that was thrown in the ocean after World War I, and you can see the acute blistering in the blisters. It's important to know that the blisters themselves usually do not contain any significant amount of mustard agent. These are Iranian casualties 5 days after Iraqi attack by mustard during the Iran-Iraq War. Choking agents, these are not as toxic as the previous agents, but are easily made and therefore can be used. They can also be produced as a result of industrial accidents. Phosgene has the order of fresh-cut grass or hay and is fairly easily made. It causes direct damage to the alveolar capillary membrane and causes an inhalation-type injury. Patients will have immediate burning, eye and airway damage, shortness of breath, and cough, and can develop pulmonary edema in 2 to 4 hours. The treatment is fresh air, wash the patient with water, remove any clothing, symptomatic management of lesions, pulmonary care, careful fluid replacement, and rest. Cyanide. Cyanide is a very toxic agent, but generally difficult to deploy in for large numbers of persons. It does inhibit the body's ability to transfer oxygen and CO2 to the capillary. The agent can be made volatile as a gas. Symptoms include seizures, respiratory, and cardiac arrest, decontamination, remove clothing, wash with water. Antidote kits are available, include intravenous sodium nitrite and sodium thiosulfate, as well as amyl nitrate. Treatment is support of oxygen and correction of acidosis. Decontamination is an important part of the response to chemical and biological agents, and basically there can be significant differences between the civilian and military world and how providers and facilities are protected. Any particular jurisdiction has to develop techniques for mass casualties, and practitioners also have to understand methods of decontamination of wounds. There are some controversies which occur in civilian healthcare facility decontamination, such as who should get personal protective equipment, how long a period of decontamination is necessary, what kind of agent detectors should be available, and how can we know if adequate decon is being done, and what to do with decontamination wastewater. In the military, the decontamination can be taught to specific groups of soldiers, and all soldiers can have some training in how to decontaminate themselves, and generally, given the circumstances, can be a fairly organized process without too great an interruption in usual operations. This is something the military does and can train for. However, in the civilian world, it is a little more difficult as we have the ongoing need for continuing patient care. Principles for decontamination on the scene: we can expect about a 5-to-1 ratio of unaffected to affected casualties. There will be far more unaffected casualties presenting because they'll be concerned about loved ones or will be worried that they haven't exposed themselves. It's important that everybody be decontaminated as soon as possible. Disrobing is one of the principal methods of decontamination, from top to bottom, and the more clothing that can be removed, the better. Water flushing is generally the best mass method, and if there is known exposure to a liquid agent, first responders have to self-decontaminate as soon as possible to avoid serious effects. There are various systems that can be deployed by fire departments to decontaminate at the scene. However, these generally will not be available at the hospital, as the fire department usually will be tied up at the scene. Decontamination methods could occur by water alone, including flushing or showering, which uses shear force and dilution to remove the chemical agent, and water alone is a very good decontamination solution. Soaps can be used to enhance things. However, they are generally have disadvantages of needing adequate supply, needing time to employ, and may also cause excess skin hydration and possibly increase absorption. Hypochlorite solutions or beach solutions are potentially an agent for decontamination. It removes, hydrolyzes, and neutralizes most biologic and chemical agents. However, not generally recommended for use in mass decontamination because of the need to dilute commercial bleaches, and it needs to be applied generally with equipment that's not available to firefighters. Also, bleach can be slow acting when it is dilute enough to use on skin, and skin contact excitement can be extensive. Laboratory studies show that chemical agents and non-toxic aqueous decontaminants need to be in contact for durations excess of 15 minutes, which basically it may be too long if a patient is having symptoms that need to be treated. Laboratory studies also suggest that bleach solutions at the 0.5% or 0.5% level may not be better than flushing with water alone. And certainly bleach can't be used around the eyes or mucous membranes or those who have abdominal, thoracic, or neural wounds. Shelter in place is an important concept for persons working in healthcare facilities. The mnemonic for remembering shelter in place is shelter, shut, and listen. This is a nationally accepted term, and basically it means to stay inside of a shelter or facility during a time of potential exposure to chemical hazards, such as a train accident or industrial release of a chemical. The process of sheltering of individuals basically involves using prearranged measures such as limiting the use of entrances and exits, securing outside air sources, communication of the danger of the outside chemical to occupants, and trying to maintain a normal business function. Wound decontamination. Patients who have been contaminated are considered contaminated until they've been certified as being decontaminated, usually by the application of a tag or marker by the decontamination team. Only nerve and blister agents pose a hazard inside of contaminated wounds. Mustard is actually very well absorbed by tissues, and nerve agent generally will not be present in high quantities within a wound, because if it were, it is generally lethal to the patient. The risk of off-gassing from a wound or foreign bodies within a wound is low, and generally there is not a need for protective respirators or in the operating room for chemical attacks. Hypochlorite solution will neutralize a contaminated foreign body in the wound, so application of a Dakin's type dressing can be done, and generally standard precautions can be used for most types of agents, except of course for smallpox, plague, or hemorrhagic fevers. If a wound needs to be explored or debrided in a patient who's been exposed to these agents, one should use butyl gloves or double latex gloves. A no-touch technique. Use instruments and not your fingers to grab any foreign bodies, shrapnel, or other objects within a wound. Abundant irrigation with saline, and use suction instead of swabbing things with sponges. And the patient can have his wound treated with a dilute solution of hypochlorite, such as Dakin's solution. Objects that are removed can be placed in a bucket of bleach, which will neutralize them. Once again, are 10 critical steps for handling a possible chem or bioterrorism offense. Most importantly, maintain an index of suspicion and follow these other guidelines. Some useful websites for if you want further information on this topic include the San Diego County Medical website, which is County Medical Society website, which is sdcms.org, and of course the CDC's bioterrorism website, which also includes information on chemical and mass trauma response as well. My email address you can contact me at is jdoucet@ucsd.edu. Thank you.